Yes, ma'am.
Does it make sense to you? Yes?
Yes, ma'am.
Very good.
Ye-
The next
Yes,
one is
yes.
pulse. How's the pulse rate in cardiogenic shock?
Increase.
It could be anything. It could be increased, it could be
Or
decreased, it could be normal, right? Let's say your patient had an MI, right? Because of the MI, the patient went into heart failure. You check the heart rate is fine, but your patient is in heart failure. Or your patient has a ventricular tachycardia, patient is in shock. How's the pulse rate? Increased. How's the patient's blood pressure? In shock. Low. Or let's say your patient had your patient has a complete heart block. Complete heart block. Complete heart block. The patient has, most of the times, patient has bradycardia, but blood pressure could be low. We call it Stokes-Adams. Stokes-Adams. So, in cardiogenic shock, pulse rate could be anything. In hypovolemic shock, how is the patient?
pulse will be feeble, I think, and the
Fast and feeble.
rate will be increased.
Yes. In neurogenic shock, how would it be? Bradycardia is common
Low,
in neurogenic.
low.
Yes. In septic shock,
Increased, I think.
yeah,
Tachycardia.
mostly high. Neurogenic shock, bradycardia.
Bradycardia.
Oh, we have neurogenic shock 2 times? Okay, that's vasovagal shock, bradycardia. It's kind of a neurogenic shock. And in anaphylactic shock, how is it? Yeah, it's tachycardic. The temperature. How is it in cardiogenic shock?
Normal. I think.
Mostly normal.
Okay.
In hypovolemic shock,
Low.
it's mostly normal, but like the patient's peripheries could be cold, but mostly it's normal. Neurogenic
Okay,
shock,
right.
Maybe hypo or hypo.
it could be anything. It could be high, it could be low. Vasovagal shock,
Normal.
vasovagal shock, mostly normal. Yes, septic shock.
Increase.
It increased.
In mostly shock, in septic shock, you mostly have fever, okay? But you could also have hypothermia. And in anaphylactic shock,
Normal.
mostly normal, yes. So as you can see, we have different things in blood pressure and pulse rate, but the only thing that is common in all forms of shocks is blood pressure. This is a definition of shock. Systolic blood pressure less than 90. You understand?
Yes.
Very good. So the treatment, as you know, is based on
Type of
the
shock.
reason. Yeah, the type of shock. Cardiogenic shock, of course, in all of them, fluid might be helpful. But generally in cardiogenic shock, you have to treat whatever is going on. Is it heart failure? Is it arrhythmia? In hypovolemic shock, you have to give the patient fluids and blood and sometimes vasopressors. We mostly don't do that. In hypovolemic patient, we don't use vasopressors. In neurogenic shock, again, you do the symptomatic treatment, but you have to find the cause. In septic shock, you give the fluids, you give the vasopressors. Also, you have to treat the infection. In anaphylactic shock, you give the fluids, you give the patient epinephrine. So you do the treatment of the low pressure, plus you treat the cause. The depressed patient has ingested a big quantity of aspirin 6 hours ago. Came to the emergency room with complaints of nausea, vomiting, increased respiration. Investigation shows highly elevated level of aspirin. It's 200 milligram per deciliter. What is your action? Gastric lavage, charcoal, hemodialysis, alkalization of the urine.
Hemodialysis.
Yes, what do you think?
Hemodialysis.
Okay, we have one hemodialysis. Anyone else has any idea?
Nausea, vomiting.
Okay, let's talk about aspirin poisoning. In all poisonings, not just aspirin poison, in all poisonings, you have two steps. You have the general measures and you have the specific measures. The specific measures is considered antidotes and other ways specific for specific poisons. Example, in aspirin poisoning, you have urinary alkalization or hemodialysis. This is something you do for aspirin poisoning. Or for paracetamol poisoning, you have N-acetylcysteine. That's an antidote you do only for paracetamol. General measures. What are general measures? The general measures are resuscitation, decontamination, symptomatic treatment. Any patient comes to you first unstable because of the poisoning, first you resuscitate the patient. Patient unstable, you insert an IV line, you start fluids. Then you have decontamination. Decontamination means if there is still some poison left that is going to be absorbed, you have to prevent that. How do we do decontamination? Example, there are some poisons that can get absorbed through skin. So if you see any of those poison is still on the patient's skin, you wash it. If the patient ingested you can do gastric lavage. You can give charcoal. You can do a technique we call whole bowel irrigation, WBI. So here's the thing. The wash, the gastric lavage and the charcoal you only give when you are sure it has been within 1 hour of the time of the ingestion. And of course, if there is no contraindication. So gastric lavage and charcoal only within 1 hour of the time of the ingestion. How many hours has it been?
6 hours.
6
Okay.
hours.
So these options are already absolutely wrong.
A and B.
A and B, absolutely wrong. So now we go to the specific treatment of aspirin poisoning. Specific treatment of aspirin poisoning depends on the level of the severity of the poisoning. Okay. Level A, mild poisoning. In mild poisoning, if you do aspirin level, it's less than 200 milligram per liter, not per deciliter, per liter. In these cases, patients are usually asymptomatic or they have mild symptoms. You do just symptomatic treatment. You keep the patient under monitoring. After 6 hours of time, if your patient is stable and the level is still below this, you can let the patient go. Moderate poisoning, the levels are between 200 and 700 milligram per liter. For these patients, you do urinary alkalinization. How much is the goal pH for your urine? How much? You are looking for a pH of 7.5 to 8.5. Okay. You understand?
Yes, yes.
Very good. How do you do urinary alkalinization? How you do urinary alkalinization? How you can make the patient's urine alcoholic?
We can use, I think, soda bicarb.
Yes, you give the patient sodium bicarb. Severe poisoning. Severe poisoning has 3 criteria. 1, patient showing any CNS features. Low level of consciousness, seizures, any features of CNS involvement. 2, metabolic acidosis. If your patient is showing metabolic acidosis in ABG, already severe poisoning. And 3, levels aspirin levels above 700 milligram per liter. Based on the things that I told you, what type of in this case, we do hemodialysis. So can you tell me, based on the things that I told you, can you tell me which type of poisoning this is? The question, mild, moderate, or severe?
It is under the severe category, ma'am,
Why?
because of the increased levels. You have mentioned 700 milligram per liter. And in the question, I think it's written as 200 milligram per
Yeah.
deciliter.
Per deciliter, exactly. It means how much in 1 liter? One deciliter is 1/10 of a liter.
Yes,
So
yes.
technically you have 2000 milligram in 1 liter, 2 grams in 1 liter. So yes, you have to go directly for hemodialysis. Of course, you have to resuscitate the patient and treat the symptomatic treatment, but there is no time to lose. You have to send the patient directly for hemodialysis. Clear?
Yes, yes.
Yes.
Next. A woman came to the officer for routine evaluation. She is found to have a pulse of 40, otherwise completely normal. History and physical examination normal. What is the most appropriate next step in the management of this patient? What do you think?
Ma'am, is it option C if the patient is otherwise completely normal?
Yeah, very
We
good.
can do
Even
that.
if the patient wasn't completely normal, of course, the first step is ECG. The first step in any abnormality of heart you find is ECG. 32-year-old woman with history of depression comes to the emergency department 30 minutes after taking a bottle of pills in an attempt to commit suicide. Blood pressure 118 to 70. The pulse is 90. Respirations are normal, 14. She refuses to tell you what she took. What is the most appropriate next step in the management of this patient? Induce emesis, gastric lavage, psychiatric consultation, naloxone, or flumazenil.
Reclavar.
That is the yeah.
We have one gastric lavage. Anyone else? So let's go option by option.
Ma'am,
Why
option A
is
is
it
under
not?
the
So here's the thing. This is always wrong. We never do that. Ever. Ever. Don't do that. Even if you just saw the patient swallow. Don't do that. Gastric lavage, we do, again, if there is no contraindication, we do within 1 hour of the time of the ingestion. This has been 30 minutes, so that is a good option. Psychiatric consultation, of course you do, but not now in the emergency room. First, make sure what's going on with the patient. Psychiatric consultation can wait for a few hours, but of course, absolutely you have to do that. Naloxone and flumazenil, the patient doesn't have any symptoms. No symptoms, no need for this. Next. Woman comes to the emergency department 1 hour after taking a bottle of pills, blood pressure 118/70, pulse 90, respiration 14. She's confused, disoriented, and lethargic. What is the most appropriate next step in the management? Flumazenil, gastric lavage, psychiatric consultation, naloxone dextrose, intubation.
Naloxone and dextrose.
Yeah, you see, the only difference between the last question and this question is the patient's symptoms. So, if the patient is unstable, patient has symptoms, you do resuscitation and you do the treatment of the symptoms. Naloxone and dextrose, you give the patient with lethargy and confusion, patient disoriented. It's both therapeutic and diagnostic. It tells you whether at least a part of the problem is hypoglycemia and or opioid poisoning. I think you have you been in the ABG session that we had before last month? No, this month. Okay,
No,
so here's your okay.
This is the
So
first class of mine.
those of you who had the ABG session, this is your chance to test yourself. Which of the following is the most likely to be found in aspirin overdose? See the measures on the site.
Yes.
Trancy. Respiratory alkalosis.
That is a good option.
Now, what about option D?
Let's talk about it. Aspirin poisoning. Okay. In all of the aspirin poisoning, the first step, mild, moderate, severe, the first step is hyperrespiration. Hyperrespiration in the earliest stages. Earliest stages, the acetyl salicylic acid affects your brain directly and causes hyperrespiration. When it causes hyperrespiration, what happens? CO2, you're going to wash out the CO2.
Yes.
CO2 comes down. What happens to pH? Because CO2 in combination with water makes an acid. So if CO2 goes down, what happens to pH?
It will increase.
Yes, pH will increase. The acid comes down, pH will go up. This is the most common scenario. Although in severe poisoning, I told you in the aspirin poisoning question, in severe poisoning, you're going to have metabolic acidosis. But severe poisoning is not as common as this one, because in all the poisonings of aspirin, you have an early stage of respiratory alkalosis. So we're looking for respiratory alkalosis. So how should be the pH?
3.
pH should be increased, either normal to increased or mildly increased. So this doesn't look like it. This is towards low. This is high. This is very low, and this is very high. So we're between A and B. So, as I told you, how should be the CO2 level?
Decreased.
CO2 level should be decreased, right? So,
Yes.
between option A and B, which one has CO2 level decreased?
The option.
Yes. Option C. Patient with depression presents with altered mental status from ingesting multiple toxic substances. You know for certain that he took some lorazepam only today, for the first time. There is no response to naloxone or dextrose. The patient is given flumazenil and immediately patients start seizing. What is the most likely cause of the seizure? Cocaine withdrawal, tricyclic antidepressants, SSRIs, aspirin, and opioid withdrawal.
Procyclic antidepressant.
Anyone else? Okay. So here's the thing. You have something, the patient has taken something that if added with flumazenil causes seizure. It's mostly not lorazepam itself. Lorazepam itself is an anti-epileptic drug against seizure. So it's not that. So here's the thing. TCAs and flumazenil, both of them, they increase the risk of seizure. Both of them. They increase the risk of seizure. Also, the mechanisms are different, but they can overlap. Especially, there is something called GABA, gamma aminobutyric acid, in your brain is an inhibitory neurotransmitter. Inhibitory neurotransmitter means it works against seizure, puts you in sleep, like that. It's inhibitory. So both of them, they work against gamma aminobutyric acid. Mostly TCA, prone you to seizure. Flumazenil inhibits this GABA, and the combination of them can make a patient having seizure, increases the risk of seizure substantially. Clear? Yes?
Yes, ma'am.
Very good. So, you know what is toxidrome? Anyone knows what is the definition of a toxidrome? Yes, can you tell me? Dr. Aksa?
Toxicrome.
Okay. You know what is a syndrome? What is a syndrome?
Toxicrome.
No, not toxidrome, just syndrome. What is a syndrome? This common word that we use every day, like 10 times in medicine. What is a syndrome? A syndrome is a cluster of signs and symptoms, sometimes even lab tests, that points towards a specific disease or a specific disorder, right? Example, Cushing's syndrome. What is Cushing's syndrome? Cushing's syndrome is a cluster of signs and symptoms: increased weight, increased central obesity, thin skin, purple hysteria, high blood sugar, high blood pressure, low immunity, changes in potassium levels. That is the Cushing's syndrome. That tells you, points towards which disorder? Increased corticosteroids, right? It doesn't tell you what is the disease exactly or why this happened. It just tells you here is the cause of the patient's symptoms is increased corticosteroid. Now, what is your job? Go find where that corticosteroid is coming from, right? Yeah?
Yes, ma'am.
Very good. So a syndrome is a cluster of signs and symptoms that points toward a specific disorder. A toxidrome is the same. A toxidrome is a cluster of signs and symptoms that points towards a specific poison. Okay. Example, patient comes to you, low level of consciousness, pinpoints pupil, hyporespiration. What is it the toxidrome of? Which poison? Low level of consciousness, hyporespiration, pinpoint pupils. This is the toxidrome of which poison? Opioids. Come on, it was easy, right?
Yes, yes, okay.
Yeah. So TCAs and any other drug with anticholinergic characteristics. TCAs are anticholinergic. Anticholinergic characteristics. They have a specific toxidrome. This is their toxidrome. Mad as a Hatter. Hatter is a character in Alice in Wonderland. Mad as a Hatter, which means they have altered mental status. Blind as a bat, which means they have mydriasis, and because of that, they have blurred vision. Red as a beet, which means they have flushed skin. Hot as a hare, they have dry skin. Dry as a bone, they have dry mucous membrane, and they have also increased temperature here. And they are full as a tank. They might have urinary retention. This is the anticholinergic toxidrome. Got it? Got it? Any questions?
Okay, okay, ma'am.
They have midriasis, so we have blurry vision or blindness.
Blurred vision mostly.
Okay.
Patient had RTA, come with GCS 12 out of 50. Pulse rate 120. Respiratory rate 60. Blood pressure 85/65. He has bruises in the left side of the chest. The most appropriate initial step: X-ray, CT scan of the head, IV fluids, tube thoracostomy.
Most appropriate.
Very good. What is the most probable diagnosis?
Hypovolemic shock.
Okay, hypovolemic shock could be an answer. But if it's hypovolemic shock, why your patient has a respiratory rate of 60?
Hmm.
What is going on? Generally, in any patient with a major trauma, like in this case, what you do has 4 steps. Step 1, primary survey. Step 2, resuscitation. Step 3, secondary survey. Step 4, definitive care. What does it mean? It means first, if the patient comes to you with a major trauma, you do ABCD. Making the patient stable, looking for the things that are killing the patient right now. Okay. Your patient might have some cuts and bruises. Your patient might have some bone fractures, but that is not what killing the patient right now. Okay. You find the things that might be killing the patient right now. Example, your patient might have a brain hemorrhage. Your patient might have tamponade. Your patient might have tension pneumothorax. Your patient might have intra-abdominal severe bleeding. You find that. In the resuscitation phase, whatever you found in the primary survey, you treat that plus some other stuff. Like what? Like inserting a Foley catheter, IV line, like that. Up to here, if you're out of here, means your patient is stable. Then you do secondary survey looking for every little injury that your patient has, and in the definitive care, you send the patient, you do all the treatments necessary to heal all the patient's injuries and traumas. So this patient, as you can see, definitely we are in the primary survey and resuscitation phase because your patient's GCS is low, heart rate unstable, blood pressure unstable, respiratory rate unstable. So something is going on in the primary survey. What would that be? As you can see, something is going on in the patient's chest, right? It's either tension pneumothorax or severe hemothorax. So what you do is that, of course, you should give the patient IV fluids, and you should later, not now, in the secondary survey, when your patient is stable, you should send the patient for imagings. But what you do now is to take care of the tension pneumothorax. Most probably your patient has tension pneumothorax or hemothorax, or maybe a combination. So what do? You have to do thoracostomy. You can first do a needle thoracostomy, and then go for tube thoracostomy, or you can go directly for tube thoracostomy if you are expert. Here's the thing. The diagnosis of tension pneumothorax is fully clinical. There is no need for an X-ray to diagnose the patient with tension pneumothorax. Tension pneumothorax has some signs and symptoms. Patient has hyperrespiration, shortness of breath, low blood pressure, tachycardia, deviation of trachea, decreased respiratory sounds in one side. So if you diagnose the patient based on the physical examination, you diagnose the patient with tension pneumothorax, it's tension pneumothorax. There is no need for any imaging. You do not lose time. You do not waste time for imaging. If you wasted time for a chest X-ray to confirm tension pneumothorax and patient died or sustained yet another injury, you're going to be convicted in court. You understand? Yes?
Yes, ma'am.
Very good. So in this case, you go for tube thoracostomy. Young boy presented with jaundice, high liver enzymes, and Kaiser-Fleischer ring. You see the ring. This brown ring. What is the most proper treatment? British anti-Lewisite, penicillamine, neferoxamine, and acetylcysteine, or none? Yeah. These are all symptoms. Jaundice, high liver enzymes, and Kaiser-Fleischer rings. They are signs of what? Anyone can tell me?
Copper intoxicity.
Yeah, they are signs of copper overload. It's either because of toxicity or because of Wilson's disease. Both of them. The treatment would be penicillamine. And the last one. Which of the following is the first test that should be performed in a patient with lower gastrointestinal massive bleeding with unstable vitals? A, nasogastric aspiration. B, upper GI endoscopy. C, proctoscopy. D, colonoscopy.
Yes.
Yes. When your patient has lower GI bleeding, this is what you do. Any gastrointestinal bleeding, The first thing, of course, make the patient stable. Second, you insert a nasogastric tube. What do you see in the nasogastric tube? If you see in the nasogastric tube, you see blood, the problem is in the upper level. So what you do, you go for upper endoscopy. If you didn't find anything in the upper endoscopy, you go for colonoscopy. But if from the beginning, you didn't find any blood in the nasogastric tube, you go for colonoscopy. Got it? Yes?
Yes, ma'am.
Very good. So your answer would, of course, be nasogastric aspiration. Well, thank you, everyone. This was your emergency session. I hope you liked it. Any questions, any problems, send me a text. Otherwise, I'll see you for your next session, and happy Eid to you all.
Thank you very much. Happy Eid.
Thank you, ma'am.